before people jump all over the measurement of serum neurofilament light chain, there's many of us who feel it is probably one of the better or the best right now characterized serum biomarkers. We have not had a great biomarker looking at MS. The only biomarker that's been used to date and probably somewhat overused and overinterpreted is the MRI. MRIs are often difficult to do. They're tedious. Patients have to lie in a machine for half an hour to an hour, sometimes be exposed to dyes. And they're snapshot pictures in time. They don't really give you the continuum. You have that one picture, and you don't want to make too much of that one picture, especially if it's only of the brain, when you've got a disease that affects the brain and the entire spinal cord, and it's just not feasible to be doing total body MRIs on patients every time. And you can easily make a mistake, right? So if the MRI hasn't changed, you can tell a patient, wow, you've been on this drug and the MRI hasn't changed. You haven't gotten any more lesions. And they'll say, well, how come my leg doesn't work? And, I guess we didn't really image the spinal cord. That's probably where you have the problem. So you can't use that biomarker to really follow patients properly and get an assessment of disease modifying medication efficacy. You'd be better off looking at something that takes in effect damage anywhere in the body. And that's where the advantage of serum neurofilament light chain comes in, because there's only one source of the light chain, and that is an axon, the wire. And the only way you're going to get that into the blood is if wires are broken and neurofilament chain is now dumped in. Now, the best place is the spinal fluid, but I haven't met too many patients who like me putting needles in their back every few months. So it's a lot easier just to get a blood test. And in fact, we're working on even making it simpler. Ongoing research right now, rather than taking a tube of blood, we're doing just like a diabetic would do. They prick their finger and they put it onto a blood spot, and we can analyze the neurofilament light chain from the blood spot. So we're trying to compare how well we can do that to, say, the tube of blood. Now, just imagine if you're a diabetic, you probably prick yourself several times a day. We could probably get folks to use these blood spots maybe even weekly, and then we'd have a true dynamic of whether or not there's any damage going on in these patients even before the MRI, since the neurofilament light chain often predicts the MRI change. It can last 2 to 3 months, and then if it suddenly goes up beyond what you'd expect from, say, the age of that patient, that's indication that there's ongoing damage, which will show up eventually on the MRI. But by the time you see the MRI, that's already too late, isn't it? So we might be able to act on the neurofilament light chain. It's predictive of how you're going to do. It can sometimes define aggressive versus mild disease. It also can be used to assess efficacy of therapy. And we're now seeing in most of the trials that they're adding serum neurofilament light chain as one of the outcome measures, the expectation being if this is a medicine that controls damage, that neurofilament light chain will drop as you take the medication, indicating that damage control has been achieved, as opposed to, say, the placebo where you'd see it continuously go up. So it's got a role for at baseline to predict how a patient's going to do. It also has a role in monitoring disease efficacy, disease-modifying medication efficacy. And it may have a role even later in patients who transition to, say, secondary progressive MS in conjunction with another biomarker, which is currently being looked at called GFAP.